Good afternoon. My name is Eric McAllister. This is going to be my final presentation for our EMS instructor methodology class. The topic I chose to cover today is opioid overdose, the epidemiology, response, and our role as EMS in managing these overdoses. So this is going to be kind of a start to finish. We're going to cover from how people begin to get hooked on opioids up to when they eventually arrest, our response as EMS, as well as new initiatives such as community paramedicine that are starting to come out and that are starting to gain traction, that are showing real positive signs in regards to repeat overdose or repeat overdoses, being able to help these people get the care that they need, being able to get them into rehab, and then to get them into um, different programs that can support them through their struggles and through their addiction. As you can see there, I put this graph on here for this first slide. It shows the increase in opioid deaths since 1999 to 2023. I know it's a little hard to see, but that gray line that you see that dramatically spikes up, that is synthetic opioids. So that is a lot of what we commonly see in the field, such as fentanyl, heroin. Those are kind of the main drugs we're going to be covering. I'm going to touch on other drugs as well and how to manage those overdoses. But the main big two we're going to stick to is synthetics like heroin and fentanyl. So the learning objectives for this lecture is going to be the students should be able to describe how opioid use often begins, explain opioid overdose pathophysiology, recognize overdose signs and symptoms, outline EMT and paramedic management steps. It is important to note for this lecture, this is going to be a mix of BLS and ALS, just because I want to give a full top-down view rather than just focusing on a specific skill level. So in reality, this would probably be more suited for an ALS presentation versus a BLS presentation, since there are ALS topics and management or ALS management tools within the presentation. So as well as being able to outline some of the management steps, be able to review NCOEMS drug dosing and interventions. So all data that's been pulled for this slide is under North Carolina state protocol. This isn't going to be something that can be used outside of the state. Understand the roles of community paramedicine. So kind of like I talked about earlier, first slide, I'm going to be touching on community paramedicine, how it's starting to develop, and their role in the overdose arrest management. So opioid use in the United States, it has remained as a leading cause of death and injury in the United States. Unfortunately, opioid overdoses are becoming more and more prevalent every day. I would argue that we're no longer in the peak of the opioid overdose epidemic, just because we're now starting to kind of get a handle on how to deal with this. We're starting to implement new tactics to try and reverse and try and curve the metrics on how many people are overdosing. We're trying to get initiatives out now to prevent this from happening. But like I talked about earlier, synthetic opioids like fentanyl drive the majority of current deaths. There are kind of more niche drugs like xylazine that are starting to pop up now. They're not as prevalent. Fentanyl, I would say, is still the big hitter just because of how cheap it is to manufacture and how easy it is to get across the border. Many victims have had previous non-fatal overdoses. A lot of times when we go out to people who have overdosed on opioids, this isn't their first time using. We don't really get examples of people experimenting, people trying out new drugs. These are experienced drug users who continue to kind of push the bar, for lack of better words. They're chasing that initial high that they felt the first time they used whatever their substance of choice is, which with a mentality like that, that will ultimately lead to an eventual overdose. As we know, EMS plays a critical role in early recognition and management. Without early intervention, these overdoses will become fatal rapidly due to, we'll get into later, kind of the pathophysiology of how overdoses occur and what it does within the body. So as we were talking about on the previous slide, kind of what opioids are and what they do, now we're going to get into more of the pathways to opioid use. So prescription opioid use after an initial surgery, unfortunately, is a pretty common gateway that we see with people who begin to get hooked on opioids. This can occur from people who have really traumatic injuries, such as back injuries, massive fractures, anything with a really long recovery time. Normally, people who have these types of injuries during their recovery process, they're going to be prescribed some sort of pain management, whether it be non-opioid or opioid. They're going to be given some form of pain management to help them during the healing process, which is prescribed by a doctor and obtained through a pharmacy. This is entirely legal means of having these medications, but unfortunately, even though these are prescribed medications given to them by a physician, the risk still runs that when people take these medications long term, it can start to lead to addiction problems. So once that prescription runs out, once their injury is healed, their body now has a chemical dependency on whatever pain medication that they were taking during their injury. So now their body is telling them, hey, we need more of whatever pill you're on. We need more, we need more, we need more. Which unfortunately is when they start looking towards illegal means of getting their medication. Another common one is development of tolerance and misuse. So these are people who will say they take narcotics daily and they eventually hit a point where their body no longer gets the high that they felt previously from whatever dose they were using. So they continue to increase and increase and increase and buy more, buy more, buy more until they finally hit the point where they use those narcotics one time, and unfortunately that's the time that they do overdose. Um, Transitioning to illicit opioids such as heroin or fentanyl, again, that kind of ties into that first bullet of people who use prescription opioids after injury or surgery. Again, like I said, these people who use these prescription opioids are people who genuinely, they just got hurt. They had a major injury and now are having to begin the recovery process, and instead of them being in pain for months and months and months, they're given these medications. Co-use with other substances is pretty common. We'll see people who use alcohol, narcotics, they'll use them in conjunction, which leads to an array of problems that we'll get into later that ultimately make it harder to manage that overdose. Psychosocial stressors and environmental factors do play a role into opioid use as well. Unfortunately, if you are brought up, whether it be in a household or in a community where it is kind of normalized and it's not seen as the problem that it is, that can lead people to kind of steer down that path, unfortunately. And then again, I know I hit on it a lot, but addiction due to previous prescriptions. That unfortunately, that is one that I see pretty commonly that ruins people's lives. People who are hardworking men and women who unfortunately they get injured, they start taking prescription medications, and it's just a cycle that they can't break. So some of the risk factors for overdoses is high opioid potency, which this applies to both the patient and the provider. So anytime that you're dealing with anytime that you're on an overdose scene and you're dealing with someone who is overdosed, always be extra careful and be extra aware of your surroundings. So if you go into, we'll say, a known house or a known residence that drug users live at, it's common that opioids occur there. Be very mindful of how you position yourself. Be very mindful of where you're putting your equipment down, where you're putting your bag down. Make sure that you have all the PPE necessary on to ensure that you don't accidentally ingest any of those substances. What I mean by rapid dose escalation is, unfortunately, sometimes people, instead of kind of working their way up with the narcotics, we'll say a good example is people who get out of jail. So we'll say someone is arrested for narcotics. They are a narcotic user. They go to prison for, we'll say, 6 months. During their time in prison, they're not really able to get the narcotics that they normally use. Well, when they're released from prison, they come back out into society. Unfortunately, they fall back into their old ways and they begin to use them again. Unfortunately, what I see a lot is people will kind of revert back to whatever dosing they were using prior to incarceration. So we'll say that if someone takes half a gram of heroin per time, they'll come out of prison and then administer half a gram of heroin to themselves. Well, for 6 months they haven't been taking heroin. Their body has lost their tolerance to that medication. So usually we'll see that and it'll lead to pretty catastrophic overdose. It'll be almost instantly. Which again, I'm jumping ahead in my own presentation, but noting that there is a decreased tolerance after abstinence.
kind of going back to the other slide as well, mixing opioids with alcohol or benzodiazepines can lead to worsening of symptoms. We're going to get into here pretty soon kind of what overdoses do in the body and what it does to central nervous system as well as the peripheral nervous system. But to just kind of touch on it a little bit now, when we're talking about opioids, we're talking about, say, the big two, heroin and fentanyl. To put it plainly, they're downers. So with drugs, we have uppers and downers. Uppers are, you think of like cocaine, MDMA, ecstasy. Those are the drugs that they make you feel good, they energize you. They heighten everything in the body. Well, with downers such as alcohol, benzodiazepines, and opioids, they slow everything down. So when you combine multiple downers together, they end up potentiating each other, leading to an increase in depression or increase in, CNS depression, respiratory depression, which we're going to get into in a little bit. Again, even just using these drugs alone is still a major risk factor and can lead to a lot of problems. Pre-existing health conditions can be exacerbated by overdose. If we have someone with respiratory issues, so they have COPD, CHF, and then they use narcotics as well, those could potentially cause flare-ups of those subsequent diseases. Let's go ahead and move on. So now, I know I kind of touched on it before on the last slide. Let's get into opioid pharmacology. So opioids bind to CNS receptor sites in the brain and the spinal cord. What we mean by that is central nervous system is kind of your main, think of like a control center. So we'll say the example I like to use is like, think of like a rocket ship. So you have a main control center that controls everything going on in the rocket. That's what your CNS system is. So this is in charge of breathing, blood flow, heartbeat, electrophysiology within the heart. All of the major vital organs and vital processes needed to live are controlled by the CNS receptors. So when these CNS receptors are dampened or diminished because of whether it be opioids, alcohol, benzodiazepines, it can cause respiratory depression and sedatory effects, meaning that these people, they just tend to kind of almost looks like they fall asleep. But instead of falling asleep in the traditional sense, what is actually happening is everything in the body is slowing down. So that includes respiratory rate, heart rate, and activity. So all of that can lead to respiratory depression, then subsequently will lead to hypoxia and potential cardiac arrest. So as y'all know, normal range for respirations is 12 to 20, and we'll say in adults. And people who overdose on narcotics, it's pretty common to see them breathe in 4 to 6 times a minute if you're lucky, which, as y'all know, that's not going to be enough. That's not enough respirations to be able to properly have cellular respiration occur, which is what kind of helps with moving oxygen through the body and that whole process. So when people overdose, those processes are all affected, which can then lead to subsequent cardiac arrest from a lack of oxygenation. The main drug that we give to reverse these effects is naloxone, which I'm going to go ahead and touch on it here. I'm probably going to touch on this 5, 6, 7 more times during this presentation. The reason that we as EMS are giving naloxone to people who have overdosed is not to strip their high away from them. The reason that we give Narcan to people who have overdosed is to reverse respiratory depression. That's something I really try and hit home for. A lot of people just assume that we give it, just because they took narcotics. If someone is breathing adequately, their oxygenation is within normal limits, you're not having to give them supplemental oxygen, and blood pressure is being maintained, heart rate is being maintained. If that person is just simply unconscious, but all of their vital signs are within normal limits, you do not give them Narcan. You do not strip them of that high. That is not our job. That is not what we are supposed to do. Doing that kind of creates the stigma of we're judging a patient based off of what they do. The real reason why we give Narcan is to reverse respiratory depression. So when someone gets into that state where their respiratory drive is diminished, that's why we give Narcan, to then allow them to start breathing back on their own. Because if they stay in a state like that, they will die from it. And then 2, you can see down in the bottom here, I got a little picture of just the difference between the central nervous system and the peripheral nervous system. I know my camera is blocking it. I don't really know how to move that around, but essentially what the central nervous system is. It composes of the brain and the spinal cord. So the brain and the spinal cord, like I said, that's like your control center. That's what sends out all of the rest of the signals to the body, which the peripheral nervous system is just all other nerves intertwined that all lead back to the brain and the spinal cord. So some of the different signs and symptoms that we use to recognize an overdose include kind of the main three I'd say are altered consciousness, unresponsiveness, slow or absent respirations, and pinpoint pupils. So all of those can be assessed relatively quickly once you arrive on scene. So we'll say that you go to a house that is known for kind of drug activity and you arrive on scene, you find your patient who is not really responding to you. You try and assess their mental status, you don't really get any response. So from there, you go to checking their respiratory rate and respiratory drive. You note that they're breathing maybe 5 to 6 times a minute at best. From there, you'll see as well probably subsequent cyanosis, which is that low oxygen saturation, which it can be seen from either looking at fingertips, kind of like the nail bed here, lips, and then on eyelids as well. All three of those will start to have like a bluish hue to them, and that'll be a good indication that someone's potentially overdosing. So once you have all three of those clinical findings, again with the pinpoint pupils, that is kind of a good example I like to use is I have people or I have my students look at their own eyes while they're in the classroom. So just pull out your phone, flip the camera around, and just look at your own eyes. Though, and that I'll kind of show them that those are what pearl pupils look like. They're equal, they're reactive to light, and they're within a normal millimeter range. With pinpoint pupils, it can be as small as looking like a flake of pepper. I mean, they're very very tight pupils. So when you have all of those accompanied with the cyanosis, those are all great clinical indicators that your patient has overdosed or they're currently overdosing. With the bradycardia or hypotension, I normally see that more when people are kind of mixing drugs. So I've had one instance where a gentleman had taken fentanyl as well as labetalol, and that was kind of when I saw that's more when bradycardia and hypotension come into play. Which, if you do have someone who is overdosed that has bradycardia and hypotension, go ahead, stick to your protocols regarding pacing, regarding symptomatic bradycardia, as well as addressing the under or the kind of overlying condition, which is the overdose that most likely is causing the subsequent signs and symptoms of bradycardia and hypotension. So some of the initial actions that an EMT or the paramedic should be taking, as always, ensure scene safety and PPE. Kind of like what I touched on earlier, going into environments with narcotics can be kind of more dangerous than traditional EMS calls just because the potential for dirty needle sticks, absorb or ingestion of narcotics, possible weapons, possibly just the type of people that you're going to deal with because unfortunately people who use narcotics don't always surround themselves with the best of people. So make sure that you're always kind of on high alert when you go into situations like these. Make sure that you're being mindful of your space around you, being mindful of the people in the room, making sure that you kind of understand where you are. Um, Always, what we should be doing with any patient is assessing our ABCs, so our airway breathing, and circulation. With that assessment, that's going to kind of what's going to help, or that's going to be what kind of helps you understand what's going on with the patient, start forming that differential diagnosis of a potential overdose. Providing ventilations. So this is something that later on I have a skills demonstration video that will be in the PowerPoint that I would show to students, but this is something that I stress on heavily. In overdose management, airway and breathing are our primary concern. So we'll play that same game of we walk in and we note that our patient's breathing 5 to 6 times a minute. Even though we understand that this is an overdose, our first action still should be ventilatory support. Reason being, hypoxia-induced aggression is very real, and a good example is when I was doing my EMT ride-alongs, we had an overdose call. This was years ago, but this was kind of first when law enforcement was starting to really carry Narcan and was really being trained on it in our area. And they arrived on scene before us, and they gave a patient 12 milligrams of Narcan before any sort of ventilatory support was provided. And safe to say, it was a very, very messy call. So what I mean by messy is whenever you give Narcan to someone, you reverse that opioid overdose. Your brain is lacking oxygen. So you've been sitting there for an undetermined amount of time, barely breathing. Your body's really not circulating oxygen like it should be. And then boom, you're snapped out of it. So now your brain is pretty much going haywire, trying to figure out, okay, what do I do? Where do I go? I don't have any oxygen. I don't have any glucose. I don't really know what to do. So it can lead to people vomiting, having projectile vomiting, very, very copious amounts of diarrhea, extreme aggression can all stem from not pre-oxygenating your patients prior to giving them Narcan. So another way that we can monitor kind of their respiratory status and their oxygen status is putting on SpO2s, putting on capnography, putting them on a 4 and a 12 lead, always for overdose patients, and getting our baseline vital signs. And then Narcan is obviously going to be our medication that we give to eventually correct the overdose and to get those opioids off of CNS receptor sites. Go or always give your Narcan per policy or per protocol. State is 0.4 to 2 milligrams, I believe, for ALS, but that's because, excuse me, we have IM and IV routes. For EMTs, it's going to be your traditional 1 to 2 milligrams, being that you give 1 milligram. Excuse me, I got the hiccups each nair. So this is from North Carolina Protocol for Overdose Management. Again, like I said, EMTs, intranasal naloxone is going to be 2 milligrams total, going to 1 milligram each nair. For the paramedics, we can use IVIO as well as advanced airways. Um, with the advanced airways, I would always kind of give caution to that, mainly because a lot of times overdoses turn into refusals, which I'm going to cover later in this PowerPoint. But unless it is, I would say, unless you're in a situation where an advanced airway is absolutely warranted, I would try and avoid it. I would stick to supraglottic airways such as not I gels, NPAs and OPAs. So reason being, when these people eventually do wake back up, having whether it be an OPA or an NPA is going to be a lot easier to manage for the patient as well as for you taking it out versus an ET tube. Um, Again, always contact medical control if there's any instances that you feel like you need to. If this is some sort of new narcotic that you haven't dealt with, Narcan's not working, and whether it's you've heard of didactic information that might be useful or you have an idea that you want to try, always if you get into a situation where you don't know what to do, contact medical control and then reference your state and local protocols for whatever agency you work at. So for an actual classroom setting, I would show this video. This is our 15-minute video that we did on skills management and demonstrations. Currently, just due to restraints, I wasn't able to create a second video for this presentation, but this video here that I made covers all of kind of the start to finish of opioid overdose arrest management from a clinical aspect. It doesn't really cover, it has some didactic, but the didactic is for how to do the actual skills themselves. So in a classroom setting, this is what I would show to my students is kind of like a, all right, let's get ready to go ahead, watch this video, then we're going to go start working on these skills together, getting the hands on. So Narcan dosing and considerations. So like I was talking about earlier, the typical intranasal or intranasal dose is 1 milligram per nostril. Reason being is that the nostrils themselves are the nares. The way this medication is being absorbed is through mucous membranes. So what that means is when you're given Narcan, this isn't like if you're given it intramuscularly or IV. This isn't being absorbed by muscles or given directly into a vein. This is being absorbed through the mucous membranes in your nose, the same membranes that make snot. How it's Wow. My brain turned off for a second. It's the same membranes that within your nose kind of produce mucus, and they don't really have a high affinity for how much medication they can absorb through them. Studies have found that 1 milligram or 1 milliliter of solution is about the most that can be absorbed through the nose before the rest is just wasted. So that's why we give 1 milligram per nostril. So how you would do that, like in the skills demonstration, the method that I like to use, I call it the pig method, which is where you just push your nose back like that, and it kind of opens up the nares a little bit better, so it makes it easier to give that intranasal medication. You can repeat this medication every 2 to 3 minutes if needed. Reference your local protocols on how many times you can give it. Be cautious of acute withdrawal symptoms. That's what I was talking about earlier with the um, kind of this projectile vomiting, excessive diarrhea, extreme aggression. There is a small possibility for seizures as well if you give too much Narcan too quick. I have never personally experienced that, but I have heard that it is a possibility. Um, Monitor for re-narcotization, which is just a fancy word for re-overdose or re-arrest. Because Narcan does wear off relatively quickly. So just because, say, you have an instance where you get out to an overdose and you are able to then correct that overdose, these people that refuse, we have to constantly tell them that, hey, just because you're up and talking and awake now, that Narcan's going to eventually wear off, which is why we always recommend that people be transported to the hospital for further monitoring, especially in instances of opioid overdose. So some of the advanced interventions, this is for ALS practitioners, would be advanced airway management as needed. Again, that as needed, very heavily focus on that. This is overdose people are not people that we should be dropping ET tubes in consistently unless it is warranted in the situation. IVIO access and fluids for hypotension if that is present. ECG and pulse oximetry monitoring as well is warranted just due to the hypoxia and the strain that that puts on the heart. Sometimes the heart can kind of throw a fit about it. I have had, like I said before, instances of bradycardia, pretty severe bradycardia in people who have overdosed to the point where we had to end up start pacing the individual even after Narcan administration. Which kind of ties into the next point. Treat dysrhythmias per ACLS and NCO EMS protocols. So if you have someone with symptomatic bradycardia, follow your ACLS and protocols for how you would treat that based on whichever agency you're at. So some of the common pitfalls that we see with people who have overdose is mixing substances. People who say they take fentanyl, methamphetamines together, it can lead to complications during treatment and kind of how we develop a treatment plan for these specific individuals. Anytime you involve multiple substances that all can either work against or work together with each other, it complicates how we treat them as providers. So, for example, if someone takes methamphetamines and fentanyl, methamphetamine is an upper, so it's a stimulant. Fentanyl is a downer, so it's a depressant. So it can lead to a wide range of issues when you mix both of those medications together. Um, Agitation or violence post reversal is extremely common to see within overdose arrest management. These people pay a lot of money for these drugs. These drugs are kind of their way of life, unfortunately, due to the addiction that they have. So when we take that high away from them, it can lead to agitation and violence from the patient directed at us. Even though we saved their life, we prevented them from dying from an opioid arrest, they still have that resentment and that aggression towards us because we took away the feelings of those narcotics from them. Refusal of transport. This is a big kind of hot topic question. Um, these individuals are allowed to refuse. If they come out of their arrest, they're alert and oriented times 4, GCS of 15. They can clear a capacity assessment and they're deemed within the right mind or within the right headspace to refuse. They're allowed to do that, even though it seems backwards because us as EMS, we want to help these people. We want to help them get better and start leading better lives. We can't force them to do that. It has to be their own decision. So another one, this is more clinical, but recurrent respiratory depression is very prevalent, unfortunately, just due to the way that narcotics works. Narcotics are only getting stronger as time goes on. So we can see, I'm starting to see a lot more that I'm having to give Narcan multiple times while en route to the hospital versus used to be you give it once and then that's it. Um, Another thing, documentation of time, dose, and response is critical, not only for your own documentation reasons, but as well for the hospital to let them know how much Narcan they've had and what the response was, which will help them determine their treatment or their kind of course of treatment as well. So for transport and handoff, continuous patient monitoring is crucial for individuals who have overdosed because there is the potential for them to re-arrest. Obviously, communicate all interventions and responses. This goes for when you're at the hospital. Anything you see on scene that you think may help the hospital staff determine a better course of care for that patient, always tell them. Um, Inform the hospital about Narcan doses and airway status. That is pretty standard as part of our handoff reports that we give to ER staff. Um, Coordinate with the ED for possible malinitiation. This isn't everywhere. This is getting more into the community paramedicine side, but if you're in a place where community paramedics are prevalent, that's where that coordination will kind of come more into play. We're going to be getting into community paramedicine and kind of post-arrest management later. I would say right now, we'll say we've reached kind of the cutting point for agencies that don't have community paramedic resources or response team. So if that's an agency that you're at, this is kind of unfortunately where, like I can say for myself as well, our agency in our county does not have community paramedicine yet. So this is kind of where our story ends with opioid arrest management. But luckily, community paramedicine is on the rise, and these arrest management teams are starting to kind of have more of a prevalence and more show within EMS. So this is right here part of the reason why these community paramedicines and these response teams started to come about was because many patients decline ED care or leave early from the ER. So we'll end up transporting them. We will reverse the arrest, and then these individuals will arrive at the hospital. So once they get to the hospital, they'll be monitored. Um, Physician will come in and say, "Hey, you need to stop using narcotics," and they'll go, "Ah, you're funny, I leave," and then they'll leave AMA. So unfortunately, these people, a lot of them, don't understand the need for rehab until it's too late. So, which leads into the next point of a high risk of repeat overdoses. Unfortunately, for those that are within EMS, know probably at least one individual who just about every week overdoses, which really it's sad. But unfortunately, that is a fact of life when you start using narcotics. It is extremely hard to kick them and to get clean because of how damaging and how addictive they are within the body. On this, the need for coordinated follow-ups and harm reduction strategies is where we really start seeing how community paramedicine is starting to shine and how it is really starting to help these individuals that are addicted to opioids and kind of starting to show them how there is a better way, there's a way out, there's a way to beat addiction. So, what is community paramedicine? So, to put it simply, this is EMS beyond 911. So, this is community paramedics are focused on outreach, harm reduction, and follow ups. One of their big initiatives is opioid overdoses. Um, so, what they do is the traditional sense of EMS is someone calls 911. Dispatcher is alerted to a problem, and then EMS subsequently responds because of said problem. How community paramedicine works is they do home visits, meaning that we'll say that Jim Bob is a known frequent opioid user. So we go out to, we'll say me, I'm EMS, so I'm on a ambulance. I go out to Jim Bob, he's overdosed. I correct the overdose, take him to the hospital. The next day, a community paramedic would then come out to Jim Bob's home, and whether it be give him a Narcan kit or as simple as just beginning a dialogue. So starting to get to know Jim Bob, saying, all right, Jim Bob, my name is so and so. I'm a community paramedic with X County. This is what I can do for you. This is how I can help you. Um, Another big one is linkage to care. So community paramedics are starting to bridge the gap between um, kind of traditional doctor's office visits and at-home care. So these community paramedics are able to come into the home and almost like a video call with a physician who is able to kind of instruct the community paramedic what they want them to do, what medications they want to give, XYZ. So it opens up an entirely new world of care to these peoples who may not be able to afford traditional kind of primary care visits. They may not have an established primary care physician. Um, Essentially, what this does is it eliminates any of those kind of arguments that someone who uses opioids could say, well, I don't have insurance, or I don't have a primary care physician, or I don't have means to be able to get to an appointment. This helps kind of bridge the gap between those. Supports long-term recovery and prevention. It has been shown that community paramedicine and their efforts is leading to a reduce in opioid arrests and opioid overdoses within their communities. So this is definitely an initiative that is showing great promise within EMS and within kind of public health as a whole. So QRTs, or quick response teams, these are teams of community paramedics that reach out to people post overdose within 72 hours. Again, they're composed of paramedics, who are kind of the traditional clinical-based practitioners, peer recovery staff, and social workers who are more versed in the sociological and the behavioral side of addiction. As a team, they provide education. They can give Narcan as well, and referrals for treatment to individuals suffering from opioid addiction or recurrent opioid overdoses. So I was fortunate enough to work with a QRT team during my paramedic capstone for a little bit, and the work they do just truly is very impressive. So essentially, they would go out to a residence. Well, in that county, they responded directly with the ambulance. So it would be kind of at time of contact, all of us would begin working together to assist this individual. And I can say with confidence, I saw that a lot more people in that county went to get help and to seek treatment versus in other counties that I've worked in or written in that have don't really focus as heavily on the community paramedicine aspect. Pre-hospital, I'll be honest with you, I practiced how to say that word probably 10 times before this presentation, and I just can't. I'll be paraffin programs. Essentially, what the medication is, excuse me, it's essentially like Suboxone. That's kind of what it is. It's a pilot program that allows paramedics to initiate maltreatment in the field, which is that assisting after arrest. So this is a medication that we use, it's a prescription medication to help slowly get people that are heavily addicted to narcotics off of narcotics. Um, it's been shown that these programs have improved treatment linkage and reduced repeat overdoses. Um, Also, it requires medical oversight and specialized training, which is why, as paramedics, we are the ones that are mainly doing this. This isn't something that we'll say that the peer advising programs or social workers are doing. This is definitely more of the community paramedicine side, the actual medication administration. Um, this is again something. This is a medication prescribed by a physician to these individuals. I'm not aware of any programs in the surrounding area that paramedics that medication is within their scope of practice. I could be mistaken, but I'm not very knowledgeable on that in regards of different agencies in my area that have it as a standing order. To my understanding, that it is something that still has to be prescribed, and it's kind of treated as like an at-home visit. So you would go out to the residence, or the community paramedic would go out to the residence and then administer the medication under a physician's order. So some of the challenges and ethical concerns. Um, for community paramedicine is scope of practice and legal boundaries. Again, this is a very new kind of emerging field within both public health and EMS. There's a lot of legal challenges that community paramedicines face. There's a lot of kind of red tape that has to be cut through to determine and secure their scope of practice, what is standing orders, what needs to be ordered by a physician. So there's a lot of kind of red tape that is still being worked through, even to this day, regarding how much community paramedicines can and cannot do. Funding and sustainability is another one. Again, this is a pretty new field, so there's not a whole lot of data backing it yet. While field providers are able to give their experiences, unfortunately, those are anecdotal. They're not backed by data or metrics yet. I would say probably within the next 5 years, this community paramedicine is just going to be standard place. I'm already starting to see a big prevalence of it within hospital systems. So I feel like after hospital systems fully kind of embrace community paramedicine and are then able to release their own studies and their own data points, that's when it's really going to set off. Stigma and patient autonomy is another one. Unfortunately, providers, they can start to begin to form stigmas and pre-assumptions about individuals who overdose and who use narcotics. So obviously we don't want people like that becoming community paramedicines because that's counterintuitive to what the initiative is about. Another big one is patient autonomy. It's like I touched on earlier in the presentation. These patients have the right to live their lives as they please. And as brute and as blunt as this is, if an individual wants to die via narcotic overdose, that is their choice. So we have to still respect patient autonomy while trying to provide them the care that they need. Safety and data sharing concerns. This is another one, again, like with how effective community paramedicine is, as well as the safety of it. Again, sending these community paramedics into environments that may not be as safe. So there are still concerns and points that have been brought up to ensure that they can kind of fine tune this program. So some of the best practices for EMS systems that don't include community paramedicine would be to incorporate harm reduction philosophies. So just teaching our employees that how to kind of talk to these patients. Standardized naloxone training and dosing, that's covered in EMT and paramedic school, but ensuring that everybody is kept up to date with it. Developing post-overdose outreach partnerships, trying to get these people contact, whether it be a third party, what have you, and then using data for quality improvement, which again, already standard across the board with a lot of EMS agencies, but just ensuring that we maintain that standard. So, quick summary, opioid overdoses are preventable with early EMS action. Naloxone remains kind of our cornerstone of opioid arrest management. Community paramedicine is starting to bridge the gaps in recovery for addicts, and ongoing education and collaboration, as we can see, is really starting to save lives. Because without that ongoing education and collaboration, paramedicine would not be what it is today and what it's going to become in the next few years. So, real quickly, I'll cover some common questions that I've gotten whenever talking about this type of topic. Does every county have community paramedics? No, unfortunately, they do not. I wish everywhere did, but this is still, again, a pretty new and emerging field. So it's not something that is wide stream yet, kind of like how paramedics are. It's not everywhere has them. How do you become a community paramedic? It varies state by state. Kind of the baseline is having your paramedic license for your state as well as your national registry is kind of the beginning steps, and then you go on to take advanced education from there. Do community paramedic programs work? Yes. So far, the data that we've seen shows that these programs are working. I don't have any specific metrics yet just because I was unfortunately unable to get any from surrounding agencies. But last one would be for when I'm in a classroom setting, I would make sure obviously to ask my students, hey, does anybody have any other questions? So from that, we could then start a dialogue of whatever their question is. But overall, with the presentation, the main focuses would obviously be on EMS's role in opioid overdose management. Just kind of how my teaching style is, I like to give a top-down view. So from the initial, we'll say, first time someone uses narcotics all the way up until their addiction and recovery stage. Just because my philosophy is, as EMS professionals, we shouldn't just be focused on the 911 call itself, but the overall person and how we can assist that person throughout their life rather than in just kind of one instance of it. So thank you all for watching. I hope you have a good day. I hope you learned something.